Typically we wait
Sorry.
a couple minutes before we get started. No, you're good, Andy. We wait before we get started because we always have roughly around 35 people kind of
Okay.
show up, and sometimes it'll kind of go above that based on the topic of the agenda.
Sure.
So probably around 9:04, 9:05. And what I'll do, Wendy, I don't know if you have any updates that you like to provide to the group really quickly before we hand it to Angela. Otherwise, the rest of the time, the bulk of the time, we will provide for Angela to be able to give us some really good information for the members.
Yeah, I think the only updates are I've been meeting with the pilot sites for CCBHC and working on the changes for state fiscal year 2000 or 2025, which will happen in January. And I hope to have those as early in July as possible. So you guys have them as much leeway as possible with your vendors. And then I'm also working on that county provider report template for your county representatives. And I hope to have that done this month. And I'll send it out to you guys and Zoe. And those are my only updates. Thank you.
Yeah, and since we've got it recorded, Wendy, I don't think we need to kind of go back unless you want to when more people get here. But we'll share the recording, right, Andy, with the committee,
Yes.
so they'll get it.
And then Zoe had one reminder, in addition to the county report template that she wanted me to mention, that we do have our summer conference coming up in July, July 17th through 19th in Fort Wayne. So if you want to attend, we'd love to have you there. So registration is open on our website.
I'll definitely be there. There is a small like ice cream shop downtown Fort Wayne I go to every time I go there. I do not know the name of it, so
There's
sorry.
a place to
I
get like
said
coney
that.
dogs too. There's a place to get like
Yeah,
authentic coney dogs there too in Fort Wayne that
yeah,
that I've been to before. So
yeah.
check that.
It's like the place looks like a coffee shop, but it's like
It
one of
might
those
be the same
places where you gotta
place.
go down. Might be. I love it. Every time we
Mhm.
go, we go to that same place. Like purposely make a trip to go there. So
Mhm.
And Demetrius, it would help me if you could kind of let me know who's on from the state. I know Wendy, you're on. I don't know if there are others, and maybe who's on from the council, if anyone. And then if it's safe to assume that everybody else is with the CMHC.
Yeah, I'm actually with the Indiana Council. Sorry, I should have introduced myself. I'm Andy Zellers. I'm with the Indiana Council. I do the grant administration and I'm a policy and research analyst as well.
Okay, thank
Great.
you.
Thank you.
And then I've met you, Wendy.
Yeah, and then Matt, one of my staff is on. If you want to introduce yourself, Matt.
You don't have to come off camera, don't worry.
I'll try and do this without coughing. I'm Matt Stuckey. I am the business system consultant under Wendy's data team.
Okay, well, great. Thanks. I really appreciate that.
think
I don't think
Lindsay usually
Lindsay
here.
sometimes attends. She's the director of system transformation, so she's over crisis and CCBHC. She sometimes attends this, but is off today because she's been working really hard on projects. So
Okay. Well, I'm glad you're able to record it. I know, this is the way it is with our health centers when we have meetings. Not everybody can attend everything. And so we do the same thing so that they can go back and look at it if they have the opportunity. Hi, Jim. I see you. Jim is actually one of my bosses, sort of. He's on my committee. Yeah.
Absolutely. So that's typically it. So we're sitting at 33, and it is 9:05. So I would like to get us officially started. But Angela, to your point, to kind of close that out, those are the folks that are on. But typically we do have Ari as well from the state. I do not see him on here yet. Wendy, I don't know if he's planning on joining or if he's off. But again, it's going to be recorded, so I think it'll be good for him to see it as well. So just officially get it started. I always like to welcome you all and thank you for your time. I know everybody's time is very valuable. I know everybody is running full tilt and wearing many different hats. So really appreciate you all for being here and being advocates to help us kind of move the marker on this. I do want to introduce Angela Boyer. Am I saying that right? Okay, I finally got it right. From IFCA, Indiana Primary Healthcare Association. They're the Indiana Council, but for the FQs is the way I like to kind of tell people. They do a lot of advocacy work on behalf of all of our FQs. Very similar to how Indiana Council and Zoe does it for all of our CCBHCs. So without further ado, I'll hand it over to you, Angela. And if everybody else wants to turn their camera off to kind of help Angela, I think that would be good.
And if
But
you
wanna-
guys don't mind if I turn mine off as well, sometimes we do work remotely and I don't have the best internet service available to me, so I may do that if you guys are okay with that.
that's fine.
Okay.
Thank you.
Okay, I'm gonna share my screen. And can you tell me, do you have the full screen view or are you seeing my presenter view?
I am still just seeing your slides in a full
Presenter
screen,
view.
not yet.
So I think I heard somebody say you were seeing presenter view. How about this?
There it is. Now it's presented.
Okay, great. Okay, so I think I'm here to talk about how we deployed a statewide strategy for using Azara drives. So if you can agree that that's the point, I'm happy to do that. Again, Demetrius shared me. My name's Angela Boyer. I'm the Chief Strategy Officer here at the Indiana Primary Healthcare Association, and I'm also the founding director of the Indiana Quality Improvement Network. And I say that because a lot of the work that we do with Drives has originated from this Quality Improvement Network. And so you're going to see this, you may hear me talk about IFCA, Indiana Primary Healthcare Association. We pronounce that PH phonetically as an F. You may hear me talk about IQIN, the Indiana Quality Improvement Network. You may even hear me use an acronym HCCN because the Indiana Quality Improvement Network is a health center controlled network. Here's what I was planning on talking about today. I was planning on talking about kind of our health IT strategy with Azara drives, what our adoption looked like, share some of the successes that we've been able to achieve, talk about how we've used it for transformation, talk a little bit about some of the advantages, and then kind of close with the lessons learned. I'm going to stop for a minute and see because I'm very flexible and I can talk on the cuff about anything. So I want to see if this sounds like it hits your sweet spot or if there's anything else that you want to make sure I talk about.
Definitely hits it for me, Angela. I'll kind of point towards Wendy to see if maybe she's got anything else that from a state's perspective she'd like to see.
No, I think this
in the
would be a
members.
great overview. Thank
Okay.
you.
Okay. And just to give you guys a little bit about my background, I have been working with underserved programs since since 1997, when I started working at Medicaid. I was at UDS, who was the fiscal agent at the time. And then I went to a managed care company that was doing Medicaid and Medicare, risk-based managed care here in Indiana. And started in provider network development and ended up being the director of both the Medicare and the Medicaid products. So I've seen things from multiple sides. I also spent 16 years over at the IU School of Medicine, learning a lot about education and training. And so I've brought in a number of lessons from that experience as well. And then in 2016, I was asked to help IFCA build a new health center controlled network. And that health center controlled network is really kind of what launched the work of Azara for us. So a little bit about the background of how we got started doing this. Again, we formed the Indiana Quality Improvement Network in 2016 with a grant from HRSA, which is similar to SAMHSA. It's the agency that funds health centers, where SAMHSA is the agency that works with, you know, on the behavioral health side of things. And we started, and I think this is really important, we started with our vision, because when we formed this network, the purpose was to bring health centers together collectively to leverage technology and data to drive initially what HRSA was seeing as quality improvement. And we have a committee of the board of the Primary Care Association that oversees the work of ICWIN. Jim happens to sit on that. Jim Skill happens to sit on that committee. And in the beginning, I was as interested in the vision as I was the technology. And so at the time, we asked lots of questions like, why are we doing this? Are we doing this because you guys are moving into patient-centered medical home? Are we doing it because HRSA has the money available? Are we doing it to drive your uniform data system reporting, which is the required reporting that health centers do for the federal government? Are you doing it to get into value-based care? Like, why are we doing this? And ultimately, the health centers decided we are doing this for our mission. And I believe that the same is likely true for all of you. But for us, it was really important to articulate what that meant. And initially, we adopted the quadruple aim, which is patient experience, population health, reducing costs, not just at the health center, but costs in the health system, and care team well-being. And that committee recently added health equity as a quintuple aim, and very intentionally asked us to put health equity at the center. It's really important because every decision that we've made along the way, while we do get external funding, we have kept in mind that it's towards these aims. And that has helped us look at Azara as more than a reporting tool. Our focus has been really about how we leverage health IT, whether it's Azara or any other kind of technology, and data to support quality and transformation. But in the middle of that, you'll see workflows. And the message that I want to share today is not only is Azara a transformation tool for us, but also our philosophy is you can give people technology, you can give people data, but unless you have workflows to support the use of the technology and data in place and know what you're aiming for, it's just technology and data. And that's the case with any technology, whether it's Azara or any other technology. And it may sound really fundamental, and I'm not trying to talk down, but it was something that was very central to us. And quite frankly, in the early days, when I was talking to the HCCNs across the other HCCNs across the nation, they were not necessarily always thinking of it that way. They were like, okay, we'll show you what the technology is, we'll show you what it can do, and now you use it. The other thing that we did in the beginning is we said, okay, if we are focused on the technology and the data, and we really want to move toward at the time was the quadruple aim, what are we talking about here? And we built a health IT roadmap, and you'll see at the bottom of the roadmap, we knocked down the stop sign because it doesn't end with the EHR, it starts with the EHR. At the time, the primary purpose a lot of people went on Azara was for the quality improvement measures. We have these federal measures that we have to report. The electronic health records weren't really accommodating that. And so Azara came in as a solution to be able to take data from any electronic health record, normalize it, and report this UDS data. But we recognized that there was going to be a lot more. And Azara at the time had things like patient registries and patient benefit planning. And those things were all essential to identifying, two things fundamentally. One is who needs what, right? Which of your patients need which kinds of services to improve their health and drive your quality measures. And second is, how can you make sure that you're not only reaching out to them and getting in, but every time you get them in, you have a plan for how you're going to treat them. What tools do you need at your fingertips to do that? That was the beginning of the work that we did. But we also recognize that it goes beyond that, right? And so this roadmap, while I'm not going to belabor every piece of it, the bottom part of the roadmap was really things that kind of can happen within your health center with the data that you have. But ultimately, in order to achieve those aims, we had to integrate data from outside the health center. We wanted to learn from each other. So we wanted benchmarking that health centers could use to learn from each other. Who are the positive outliers? Who needs help? Who are the innovators? And so we needed a central centralized data architecture, and ultimately we were going to need claims data. And we need ways to identify our patient risks and needs so that we could respond appropriately based on the risk. We needed to understand their experiences outside of their healthcare that are affecting their healthcare. And ultimately, we needed to have a tool that we could use to do all kinds of advanced analytics. So this roadmap has been modified very modestly over the years, and it is, I think, been a great thing for us because, again, when we ask the questions, what are we going to focus on and what we're not going to focus on? We have this roadmap. And if we have new ideas that come up, it goes to that committee and they say, yes, this is important, or no, it's not. I'm just going to share this slide. You're going to get these slides afterwards. You're going to get the recording afterwards. But Azara had a lot of solutions. When I came in, IFCA had already signed a contract with Azara, and there were 4 health centers on Azara. But we still looked at other systems. We didn't do a competitive bid the way you guys are doing. And I think that that's a great idea. But we really looked at our health IT roadmap. We got together with other health center control networks across the nation. We looked at how they made decisions. We asked vendors to share what their capabilities were. We just didn't get into the pricing conversation. And ultimately, because we already had an agreement in place, and because we were hearing that our agreement was, financially favorable, we stayed with Azara. The other thing that we did was we worked with Azara. So we had this roadmap that was bigger than their tool. We knew what we needed and where we wanted to go, and we knew what Azara had. But actually, we brought in their senior vice president of, I think at the time it was Health Center Success. Now I think it's clinical innovation. And we've continued to work with her through all these years. Her name is Luann Kimker. And we sat down with her and we told her everything we needed on the roadmap, what kind of programming we needed to deliver, what kind of data we needed to have in order to deliver that programming, what tools the health centers needed, who we needed to start getting data from, how we wanted to work with payers. And quite frankly, Luann has told us that they built their roadmap off our roadmap. And I say that because when you look at Azara or any other tool, I would suggest that you understand how willing the vendor is to work with you, because CCBHCs are going to need more than what's currently in Azara. And I would recommend that there is no technology that's going to give you everything you need. But what you really need is a willing partner. And so I'm just throwing that out there. I am not a salesperson for Azara. There are a lot of things with Azara that I wish would improve. As a matter of fact, I'm in a national Azara. It's like a voluntary Azara leadership group with other Azara users across the nation. And we're always pushing Azara. We prioritize what the nation needs, and we're always pushing them to make enhancements and innovations and those kinds of things. So I just bring that up because I think it's really important that whoever you work with is willing to meet the needs that you have uniquely. And the other thing that I want to share, so that first message is it goes beyond reporting. It's a transformation tool. The second message is you can work with the people at Azara to build what it is that you need. But again, unless you're actually doing something to use it, you may not see the change that you want to see at the pace that you could potentially see it. So we had Azara in place. We had a health IT roadmap. We had some health centers who had adopted, but we didn't yet have network-wide adoption. We were showing people how to use Azara, but we were trying to figure out how do we work collaboratively, us as staff at the network, with the centers who are in the network, to really be able to leverage this tool and other tools. And so our adoption strategy, I guess the overview is that we really identified key areas of that health IT roadmap that could be supported by drives. We focused on different areas of our programming regularly in response to those areas that were on our roadmap. We identified sort of super users and responsible people for the initiatives that we were doing and the program that we were doing. And we developed goals and metrics to assess the success of the network. And we think that we feel like that was really important for us to be able to be successful in delivering the kind of programming that was important to adopt for each health center to be able to adopt Azara drives, but us collectively to adopt a tool and learn from it. Some of the things that we do with the tool, and I bring this up because it just starts with the technology, right? And I want you guys to think about it because the tool is only as good as you can make it, right? So we do things like look at health center usage. We look at how many health centers are running which reports, how many times they're running those reports, you know, who in the organization are running the reports, what are the titles of those people, to understand how it's being used. And then we look at that in relationship to quality data to understand where are we seeing positive outliers who are using the tool and seeing success. And then we talk with them and we bring them in to talk with others. We really focus on data hygiene and training people on how to use the tool, but also how to maintain the data. Because anytime an electronic health record has an update, it could potentially break a link in the connection to Azara, or if you change a workflow, it could break a link. So that's something that we have a team that looks at data monthly, and you know, they look and see if somebody's changed, you know, like unexpectedly, and they'll reach out to them and see if there's something going on with the mapping. Again, it's been a tool for our clinical quality, just a tool in the tool chest with other things, but we've used this tool to drive change in quality, and it has been very successful. As a matter of fact, I've gone across the nation speaking to other states about how we're leveraging the tool, and we now have, like I said, we have an Azara strategy group. We also have a national Azara user group. So it's people like our team here at the association who are using the tool with health centers. We are always working together to figure out collaboratively, you know, who's doing some really cool things that we could disseminate. And it's a transformation tool. It's helped us move from just looking at quality and just looking at how we have been delivering care to how we want to transform care and be ready, for example, for future payment opportunities. And it also has some financial and operational tools that we haven't dug into very deeply until very recently and are starting to dig in deeper on. So for us, it's about the technology, but it's also about user engagement. So I said we're monitoring usage at the center level. We have created a tool because every health center, and I'm sure every CMHC and every CCBHC in the future is going to have staff turnover. So we have a tool now that's just a tool that's for new staff that come in, where we've identified these are the fundamental things you need. There's lots of resources out in Azara's learning system, but these are the things that we recognize you're going to need. And so we're going to help you sort through all that. We do meets and greets with our new quality leads and the Azara super users. We have a SharePoint site for our health centers, and we have a Drives resource page on that site. We're always looking at tickets that health centers put into Drives to see if we're seeing trends, or to see if Azara is actually closing those tickets in a timely manner, things like that. And we're always reviewing implementation of projects. So we have health centers coming on to new modules and new health centers coming on, and we work with Azara. We meet with them monthly, and we really review the progress of those implementations. So again, it's not just about having the technology, it's how are you going to support that. The other thing that I want to share is that when you talk about measurement, a lot of times when you look at quality improvement processes, people start with a measure. And they say, okay, I want to improve diabetes. And they'll do PDSAs or lean processes, and they'll work on that measure, and they'll see improvement. And then they'll move to another measure, and they can lose ground on that first measure because their focus has moved to another measure. What we have focused on is systems of care, right? And I think that's another key thing, is using any tool. I believe the way we look at measures now is that they help us assess whether or not those systems are working, right? And if we see that they're not, then we look at the system for that measure again, or whatever the process is. And we kind of cluster our measures, because a lot of times you can do the exact same thing and it's going to impact everything that you do, right? So good patient visit planning, good care gap identification, good population monitoring, good outreach. Those things are going to affect every measure that you work on. So we focus on that. And then we've wrapped a lot of services around that. We have a community of practice called Focus on Quality. We have an Azara Drives user group. We have a Health IT user group. We leverage some national resources from our National Association of Community Health Centers around value transformation. We've identified a number of changes that health centers could adopt around that value transformation framework. And then we leverage a national tool called Prepare, which is a protocol for responding and assessing patient access risks and experiences to identify social risk needs. For clinical quality, we're always looking at the data to identify outliers and to identify folks who may have questionable data, but also folks that may be struggling. We actually look at our health centers from a population health lens because we have some like super users that are doing great and they have certain needs. We have the folks who are in the middle who are always, you know, able and have capacity to move on things. And then we have some newer, more novice health centers or maybe some smaller health centers that might be lagging. And how can we take some of the strategies that others are using and help them use it? And again, we think of this, we look at Azara and quality through a strategic lens too, right? So how can we use this beyond clinical interventions? How can we use it when we are talking to vendors about group purchasing opportunities, talking to funders? How do we use it in the policy conversations, right? It's bigger than just what are we doing on the ground with quality? And how do we use it with partners? We look at our populations to identify disparities. So whether it's folks who are living with behavioral health diagnoses, or folks who, you know, who have different sexual orientation and gender identities, racial and ethnic disparities, all, you know, housing disparities, all those kind of things. And we've developed a number of dashboards at the network level. And that's the nice thing about Azara too, is that you can do that like at the network or a state level, that a health center can just like copy and use it for their health center. And then we can review network performance from those dashboards together. And this is just, you guys have probably seen Azara. This is a network view of Azara. For one measure, it happens to be hypertension around down the bottom. I've cut it off for their own, you know, privacy, but that down the bottom is a list of all the health centers, and we can see where every health center is performing on what are standardized measures. The data has been normalized, so you're comparing apples to apples. And we use this in a couple ways, right? We use this to see who's performing high. We reach out to them, see what they're doing. We use it to see if we're seeing changes in health centers that are dropping from where they've been. It has trending reports that you can look at. You can filter, slice, dice by any kind of number of things. And I'm sure you've seen all of that technology. And from that, we again have developed some dashboards. I'm not going to get into it. We kind of cluster our work in some different areas. And we'll develop these dashboards so that we can kind of look at things from different viewpoints. And again, any health center can adopt that, any dashboards that we've built locally just by making copy and renaming it. This is a very busy slide, but you know, again, the point that I want to reiterate is that it's not just technology. We leverage just technology in a number of different peer groups that we have across the association. Focus on Quality as our user group, Health IT user group, obviously, but also in our SDOH champions peer group, in our clinical and behavioral health peer groups, in our integrated peer calls. And we bring in subject experts as well. And then we have lots of other things to support that. We have, like we just talked about today, we're giving you guys a recording of this in the slides because there are people who couldn't be here. We have a publication we call iQuint On Demand, where we put all of that information so that people can access it asynchronously. We have engagement calls with each of our health centers where we're kind of talking about where they want to progress and, you know, what their status is and how we can help them, or maybe identify some promising practice that we think we can disseminate across the network. We are engaging with lots of partners. My job, in fact, is probably now predominantly partner engagement in value-based care, but to create partnerships that can help benefit the mission of the health centers, the patients that they serve, who are also, you know, the patients that you guys serve, the patients that FSSA and the Division of Mental Health are interested in serving, OPP. We have that SharePoint site. We have team groups for different groups. Our Health IT group is the one that uses those groups most frequently, and probably Demetrius is one of the super users on those groups. And then when we can identify partners who have funding, we make Health IT funding available to the health centers so that they can adopt new things. But we've also applied a number of theories that are used in other settings to the work that we do with our health centers. So everything that we do is based on adult learning theory. That's why we have collaborative learning sessions that are kind of problem-based and learn from each other. We use the trans-theoretical model stages of change to understand where health centers are in just basic understanding, knowledge, readiness for change, those kinds of things. We use motivational interviewing to understand what their goals are, where they want to go. We try to really model integration of care by the way we deliver things. We have our own technology that we use with our engagement. We have a customer relationship management system. It's kind of like our electronic health record for how we engage with our health centers. And we look at our health centers not as though they're all the same, but as though they're all unique, right? And we apply principles of population health to our health centers. Like we stratify them to see, which health centers need which kinds of supports. By doing that, we have achieved some successes. The first time that Azara created the opportunity for us to compare a current year to a baseline year, we compared our 2019 reporting to our 2017 reporting, and we saw that the Azara users had improved on every clinical quality measure, every single one of them, significantly on some of them. We look again after COVID, because a lot happened during COVID, and health centers had still improved from pre-COVID levels on 11 measures. This is really significant because nationally, health centers had only gotten back to baseline on 2 measures and improved modestly by 0.1% on 1 measure. So there was something that we were doing here, even though there were other states that were using Azara, that was different. And that's why I really want, and we didn't lose the denominator, right? We kept the patients. That's why I think it's really important that you guys think strategically about how you use it, because I think it's not just about the reporting, right? It's all this other stuff that surrounds that makes it possible to leverage the technology and the data to really drive change. And every patient who gets an early detection of breast cancer is more likely to survive. Every patient who can quit smoking is more likely to live longer, right? Every patient whose diabetes is under control is less likely to lose a limb or lose the function of their kidneys or die early. And so for us, that's the so what. Are we changing the lives of people we serve by using all the tools at our disposal and learning from each other? This year in 2020, when we looked, I was very excited because we were still outpacing the nation on improvement. But the thing that was the most shocking for us is that Indiana, who was used to not being the best in the nation, when we started this work in 2016, in fact, we were in the lowest quartile of the nation on almost all of the UDS measures, is now outpacing the nation on 8 measures, critical measures that are important to some of the chronic diseases that have the most impact on people, right? And of course, diabetes lower is better. And critical measures that are helping to identify and prevent disease and identify things early. And we're really excited about that. The other thing that we did was we do some analysis of all the data. Some of our other peer states do this analysis as well. And we looked at where we were from a quartile perspective in the nation now. And we are no longer at the bottom in all measures. There's only 3 measures where we struggle, and behavioral health, not shockingly, is one of them. But we're at the top quartile on 2 measures, and in the second on 6 more, right? And that's where I want to just help you understand how the power of this work can unlock change, because we know where we're starting in behavioral health, right? And can we use some of these tools not only to impact the clinical, medical issues that our patients and your patients are experiencing, but also their behavioral health needs. Another little thing that I just kind of wanted to share with you is I'm really interested in systems of care, and the way the measures work in Azara is they're discrete individual measures, right? And you could kind of look at every measure and see how health centers were doing. And I was seeing kind of like all kinds of, there was people that kind of floated to the top a lot, but there was all kinds of places where, like for one measure, you know, maybe the smallest health center was the best. But I wanted to see like who was doing well across the board. So we created this way to look at data. This is not within Azara. We did this analysis outside of Azara with the national UDS data. But we looked at where every health center performed on every UDS measure and assigned them a percentile on each of those measures. Then we created a composite percentile ranking by adding up those percentile scores and dividing by the number of measures they report on, because not every health center reports on every measure. And what we saw was this variation, right? And so what we recognized was that health centers who are performing, you know, high are likely implementing good systems of care across the board. We thought that was really important, and that's really kind of transformed the way we look at things. And I will tell you that, and this is all health centers in the state, regardless of where they're on Azara or not, but I can tell you that all of them that are at the top are on Azara. We also looked at different cohorts of health centers. We looked at if they were in the IQUIN network or not. And that had some impact. We looked at whether they were FQHCs or lookalike or not. And we saw a lot of impact there, but those lookalikes were more novice. So we looked to see if they were on Azara or not. And that's where we saw a huge impact. Those health centers who were on Azara were performing significantly better as far as their composite percentile ranking than those health centers who weren't. And I say that because we used the information that I just showed you, which is the fact that we can improve and the fact that the tool is helping us improve when we talk to stakeholders to get investment, including payers and folks like IHI. When I talk about our transformation, you know, we really wanted to move from getting paid for the stuff that we do to getting paid for the value that we create, right? So we're focused on the quintuple aim. We want to produce those outcomes, and we want to receive payment based on those outcomes, not just on what we produce. And so we started in 2018 with creating a risk algorithm within Azara Drives. It helps us stratify our patients by risk. We do that for 3 different patient categories: pediatrics, adults, and geriatrics. And it helps us look at what interventions we need for each patient, because we can't do the same level of care for everyone. We just don't have the capacity to do that. We want to target the intensity of care to the patient's need and complexity. And the things that are in that algorithm are medical diagnoses, behavioral diagnoses, certain medications, vitals, and, you know, lab results, account of their social risk factors, utilization factors, how many emergency department admissions and inpatient admissions they have, things like that. We also kind of developed a framework to transform the payment model by transforming the care model. And in 2019, we rolled out a transformation framework that helped health centers see where does your focus change as you move from your current model to what health centers have adopted as patient-centered medical home. Likely you guys are leveraging CCBHC that way. Into ways that are getting paid by payers, starting with things like pay for performance and understanding you have members assigned to you that may not yet be your patients that are in those denominators. It's HEDIS measures, not UDS measures, right? How do we focus on the visits and getting people in the visits so that we can close the payer care gaps as well as, you know, the care gaps that you're seeing for your existing patients? And then what are the different things that you need to look at when you move into things like shared savings, even upside risk? Like if you're reducing cost of care, right, what are the interventions that you can implement using the tools that you have to affect that? And ultimately, if health centers want to go in the direction of alternative payment, you know, what we would need to do from really understanding cost profiles to take on some risk. Like I said, there are lots of transformation tools within Azara. A couple things I want to point out to you is the 2 areas where we've been doing a lot of data sharing is around transitions of care with the Indiana Health Information Exchange. So we pilot with 8 health centers. I think now we have 20 health centers who are receiving daily alerts of admissions, discharges, and transfers from ED and inpatient settings into Azara Drives. And the health centers can, you know, pull those up the next day And what a lot of health centers do then is then they'll like click by risk, they'll like start with their high risk patients and see who's been in the ED. Or they may sort that list by, there's a variable in there, like the number of ED visits in the last 6 months or the number of inpatient visits in the last year or 6 months. I'm sorry, I'm not the end user for that. I don't know exactly what the metric is. But again, it's just a tool that's beyond what we originally were using it for, right? A lot of health centers did it because they could do their UDS measures, and now we're using it for all kinds of things. We're also exchanging data with payers now. We now have 3 of the 4 MCEs that are on Hoosier Healthwise and Indiana plan, exchanging data or implementing that project where they're sending over the attribution lists, the care gap files, and claims data that's consumed by Azara. And then Azara, in one click, can reconcile that data to who is a patient in the EHR, who is not. So who is matched with health center, who is not, and then who believes the care gap is closed or not, right? Because sometimes there's discrepancies between the health plan and the health center. And, for those unmatched members who may be getting care elsewhere and who's not getting any care at all. And so we're developing a roadmap for every one of those different categories of patients. And then the health plans are getting supplemental data so that they can close a lot of HEDIS care gaps without having to reach out to health center for primary source verification, because Azara is validated both in patient center medical home. It has a number of validated measures to help them receive that accreditation. I would encourage them to get validated for CCBHC as well, however that goes, if you work with Azara. But they're also validated for HEDIS measures. And so a health plan can accept an Azara report and not have to go back to primary source verification. I'm looking at time. I'm gonna go quick now. For transformation, I will just say that every health center we were recently assessed for readiness for value-based payment, places we scored best were in health IT and care model. And that's important because that's what we've leveraged Azara for. We have been transforming from sort of foundational things, like what are you doing with your patients, to do good outreach and good patient planning, so you're closing the care gap, to things that we need for transformation, including behavioral health integration. When I worked at MaxiCare, my highest cost patients that we could really do something about were ones that had behavioral health comorbidities. So if you've got a chronic disease and a behavioral health diagnosis, and I'm not talking serious mental illness always, it's depression and anxiety, your cost of hire, your ability to manage your own care and have successful outcomes is challenged. And so that's really important to us. So what have we seen as some of the advantages of Azara? First, Azara has been able to connect disparate electronic health records. We have not yet found a health record that Azara can't map to. And from folks that I talk to across the nation, and I'm very engaged nationally, not every population health technology can say the same thing. It uses normalized data, so apples to apples, and standardized measure definitions from structured data fields so that you can really use the data and trust the data. It gives us a population health view. So the electronic health record is great at giving you a view to that patient and that record while you're with that patient, but they're not yet great at letting you see the whole population of patients in the ways that health centers want to. It allows the health center to see their performance compared to others and do their own performance monitoring, but it also allows us to see at the network level. It's been the thing that's facilitated our shared learning. It allows us to deploy things at the network level. So things like the risk algorithm and the work with iHigh and the work with payers. And, potentially we could all go to a standardized electronic patient outreach, automated patient outreach tool if the network chose to do things like that. And it's much less expensive when you can do that and when you can integrate, through one tool and one data file share than through 25, which is how many health centers we have on Azara now. It allows us to do new measure development, which has been great. So a lot of health centers work with the Department of Health, and so Azara can create new measures. They have hundreds of measures, so sometimes it's just the state's looking at something slightly different, and they can take an existing measure and just modify it. It doesn't cost a thing. Or it's something that needs to be developed from scratch. We can make sure it's developed the way the end user wants and needs it. We may have to pay for that, but we can pay for it once and every health center can have access. And it gives us the opportunity to do external data exchange and external reporting, not only with payers, but also HRSA, which is who funds health centers, is now doing something called UDS Plus. And so they're asking health centers to begin reporting data at the patient level on all of their measures so that they can do additional analysis. Right now, it's de-identified data, but they want to do it from a FHIR exchange, right? We have not yet found an EHR who's able to do that. So as a matter of fact, when they did the first testing this year, it was all population health technologies that were validated. And Azara is the tool that a lot of health centers are moving to because our EHR can't do this, and Azara can. And I'm proud to say that Indiana had the most health centers reporting UDS Plus this voluntary year than any other state. The predominance of reporting came from Indiana. One of the other advantages I see, and I'm not here selling Azara. I'm here because I am all about seeing the health of Hoosiers improve. But there could be some potential advantages of leveraging a common technology across programs, right? And so you might want to think about that. It might help reduce costs. There may be things that we can collaborate on. We have peers in other states who are doing this kind of work collaboratively with CMHCs, CCBHCs. And so, you have to make the decision that's right for you. But if it's important to you to have the opportunity to collaborate, that may be an opportunity. And the nice thing about Azara is that if somebody's already implemented and then there's another program that they want to work with, so for example, the payers, that other program doesn't have to re-implement Azara. They can have a view of those health centers are already in Azara that's just specific to, those health centers that entity is working with. And, potentially just those patients, if there are patients that need to be segregated out. So that's just something to think about that may be helpful for folks to think about. Again, for us, Azara has helped us progress on the health IT roadmap. It's got, we have worked with them strategically to expand the functionality. I'm on the national Azara user group. We push them nationally. Or Azara leadership group, we push them nationally. It gives us this opportunity to really make difference and adopt that PCMH care model and drive quality. It has been the tool that has been central for partner engagement. I'm just going to say, for example, working with Indiana Health Information Exchange is very expensive. And because we've been able to bring this single file data exchange, the cost savings are dramatic. Can't share the number with you, but dramatic. And actually, as a benefit, we're getting part of the tools that Azara would have to implement in the EHR, the longitudinal care record, that comes along with the opportunity that we were able to negotiate through the single file exchange. We did during COVID, health centers were part of the emergency response with a program called Health Center Virtual Care at Home. And when we did this through FSSA, we did, and the Department of Homeland Security. And when they asked us what we needed, we were just starting to do this work with IHI, and we said, we need you to invest in this because we need to know what's happening with our patients outside, particularly if they have chronic diseases or if they're COVID positive, we need to know what's happening with them so that we can support them. And so they used high-tech dollars and they drew down dollars under high-tech to support the implementation of Azara and the costs of the IHI exchange. That high-tech dollar, those high-tech dollars are no longer available, but they have approval and OMPP has approval in concept to validate Azara to be able to draw down matching funds from CMS for Azara as well. The state hasn't gone there with this yet because they have a lot of priorities. And of course, the work that you're doing in behavioral health is one of the biggest priorities, and the movement to long-term support services under managed care is another. And the Department of Health has been able to bring down CDC funds to support this work as well. And, we're continuing to identify entities like the payers and others that have common mission where, if they can invest in this technology, we can help them achieve the goals that they want. It gives us the opportunity to do some group purchasing in new ways. And, just those shared enhancements that we've been able to work through with Azara have been advantageous. And we have a collaboration with Azara. We have an ongoing consultant agreement with their Senior VP of Clinical Innovation, where we're talking about what our vision and strategy is, and they're helping us understand how they can modify and improve Azara to meet that. I'm part of Azara user group. We're part of the Azara user group where we're learning from others across the nation, and there are going to be other states that are doing CCBHC, and that may be a learning opportunity for all of you. Azara is in, gosh, over 30 states now. It's ubiquitous in the health center movement because it's been so effective. We have been able to do future forecasting with them so that they can build things that they see are coming down the line. And it's just been part of our shared transformation and evolution. And we've shared that with Azara because they've been a willing partner. What are some of the lessons learned? It's not about the data. It's all about the data, but it's not just about the data, right? That this technology only works if there are processes in place to leverage the technology to create the change you want, and the right people utilizing those processes to make that change. And there has to be a way to fund it. There has to be a business case. Also, you have to have a vision for how you want to use it, not just thinking about what's the short term, but what's the long-term vision. You have to think about the systems that you want to change and how that technology can help you reach your vision by helping you change those systems. And then just think about partnership together with the health centers, partnership between the state and the health centers, the council and the health centers, partnership with other states, partnership with payers, with IHI, with community-based organizations, right? Just think about this is a tool to help leverage those kinds of partnerships and get the tools and data that you need to do the work that's so important to the work that you do. What did we learn? Like, Azara is not perfect, but also we weren't perfect. We grew the use of Azara one health center at a time, and we still don't have all the health centers on. We've got 25 on, we probably have 4 more coming on this year, but we have 39 FQHCs and lookalikes. Health centers value autonomy, so not all the health centers are on all the same things. And that flexibility has pros, but it also has challenges and cons. So think about those kinds of things. How you're going to give health centers the opportunity to use the tools they need, but whether you're going to have flexibility of everybody doing that or not. I believe we missed some opportunities to deploy modules collectively. Part of that is we've been growing together. Our vision has been growing together. We've struggled with funding. You guys are very fortunate because you're thinking about this upfront and you have some funding that you can invest in this, and you might want to think about the future things you want to invest in. Well, we've really struggled with funding. It has some gaps that we would like to see filled. So I would say one of the biggest gaps that I would like to see them fill, and we are pushing for naturally, is geocoding patients. Because right now, for example, we've done some work around rural populations. They don't have a good way to do that. We would like to potentially be able to do some reporting by congressional districts, right? We would, potentially could have opportunities to do reporting at the county level. Azara doesn't have that built out. And I think you need to come in with your eyes wide open to look at what's the geographic reporting that you need and really push Azara to develop that. And then potentially visualize that with maps. They don't have that right now. And so again, I just want to be straightforward about that. Also, because Azara is kind of based on the entity that is the covered entity for that patient data, there's duplicating patients within the entire system. So for example, if you have a patient that goes to Aspire for some services and then another community mental health center for other services, that patient's going to be unique in each of those records, and they're not currently matching those. So deduplicating patients and matching those patients is going to be important. And they can't do all things. They can do the things that they can create in their interface, but you can't create customized reporting and customized queries in Azara unless you do that by having them build a measure, which can potentially be costly. So we've had to get a copy of the Azara data warehouse to do some of the things that we want to do. I'm just going to be honest about that. Now, to be fair, not any vendor is going to be able to do everything that you want. And I look at it kind of like as, purchasing a home. You may love the kitchen in this home and the yard in the other home and the fireplace place and a third home, but ultimately you have to pick one that you think is going to meet your needs and grow with you. And so I'm not here selling Azara. I'm just telling you how we use this particular technology. But I do see some benefits to it. You are not just reporting, right? You guys are currently in the process of dramatic transformation. And so just to have that awareness that you want a tool that's flexible to grow with you as you transform, I think is really important. And I think that's, oh, and then just some things about administration, right? We didn't think about this in the beginning, and it's a lot of work, right? New functionality can cost things. You got to think about that, plan for that. New modules, meaning we have to sign new scopes of work and there are new costs. We have to manage all of that. The contract with Azara comes through us so that we can get favorable pricing for our health centers. But that means we have to work with all of our health centers and bring in all the third parties, and we have to do the invoicing and payment and collections and all that. That's just administrative work. I don't think I left enough time for conversation, but I'm happy to stay if anybody wants to. And we've got what, 4 minutes now. I'm gonna stop sharing and turn the camera back on.
Yeah,
I don't know if I hit on what we needed to hear.
absolutely. Thank you so much, Angela. I don't know, and I don't want to speak for other people, but that was amazing. So thank you so much for all of that information. I think it hit on a lot of things that we have been kind of getting questions about. Folks have been kind of confused and wondering what the strategy or benefit is for them to kind of get on a platform like this at the state level. So I think you have went above and beyond. So thank you so much. I did not see any questions in the chat. But I'm pretty sure some folks need to digest all that information, and some questions may come out after the fact. So I will compile those and share them with you if questions come our way, so that way you can kind of answer them. For everybody, the presentation or the slides that Angela was presenting, I did put them in the chat if you have not seen them. I also uploaded them to the member portal, so we will make sure that you all have them as well as the recording. Wendy, do you have anything that you wanted to add to the calls?
I didn't. It sounds a lot like what we're wanting to build. So I appreciate your sharing your vision so everybody can hear it.
Agreed. Anybody have any questions? I'm sorry, I didn't check and see if anybody raised their hand. I don't see any hands either. All right.
And I just want
Nothing
to,
else?
speak for IFCA. We so much value the work that your CMHCs, hopefully soon to become CCBHCs, are doing across the state. We want to be good partners. We want to share and learn. We want to lift all boats. So don't hesitate to reach out to us. I know Lindsay kind of works with you guys on some things, and she's a great resource as well. But, we're all partners trying to achieve the same mission together. And I think that's important. I thought it was important.
Agreed.
I'm sure you know that, but.
I absolutely agree. So thank you so much, Angela, again. And again, thank you everyone on the call and those that aren't able to make it, because I know you'll have some folks review the recording. So thanks everybody for all that you do. If nothing else, we'll call it adjourned. Thank you.